Thank you, Prof. My presentation on the effect of steroid on the eyes is based on the study done by my colleagues, Nas, and myself, under supervision of Professor Richard Howie and Larry and Ray and Krishna and Jeff. So I would like to acknowledge the contribution of the author and the co-authors. Let me start with my own patient. 2 months ago, I found this patient. He's a 63 years old man. He has rhinitis since he was a young boy, but the rhinitis is just mild severity and intermittent. The skin prick test was positive to mites to confirm the diagnosis of allergic rhinitis. And then 15 years ago, the rhinitis was aggravated by dust, and he had severe symptoms. And we received intranasal steroid for controlling the rhinitis. And after well controlled, the medication was stepped down to antihistamines. And he never used intranasal steroid again for the past 15 years. But 5 years ago, he had visual impairment, and he was diagnosed by the ophthalmologist as steroid-induced glaucoma. And he received the treatment for his eye problem. And during the past 6 months, he was referred to me because he has severe rhinorrhea, and it was not uncontrolled by antihistamines and any second-generation antihistamines. So one question coming up to my mind, is this really steroid-induced glaucoma when he just received steroid 15 years ago and never used it again? And the second question is, when he really have ocular hypertension now, and the rhinitis cannot be controlled by antihistamines, can we use intranasal steroid to this patient? If we look at the mechanism of the steroid induce the intraocular pressure elevation, actually it's not clear and nobody really knows what's happening. But in some way, it affects trabecular meshwork. There may be the accumulation of the steroid particle or the polymer or protein matrix, or they increase the resistance at the outflow. And the other thing is the synthesis of prostaglandin is reduced by steroid, and prostaglandin regulates the aqueous outflow. So in some way, it affects the eyes and it increases the intraocular pressure. And also for steroid cataract, same story. Nobody really knows what's happening, and nobody knows exactly the mechanism of action of steroid cataract. But in some way, steroid just enter the lens fiber, it reacts with lens crystalline, and there is protein aggregation and produce of new lens fiber. And this accumulation is located at the posterior subcapsular region. So in some way, I think steroids just affect the eyes, but it's not as simple as when you take steroid, you have glaucoma, and when you take steroid, you have cataract, because there are many factors. We found that if you take intranasal steroid plus oral steroid, or you take intranasal steroid plus inhaled steroid, or you use steroid with this and that and this and that, there is a greater risk that you have eye problem. And the other thing is the dosage. If you use high doses of steroid, it increases the risk. And the duration of the steroid use is important. If you use it in the long term, you have greater risk. And other factors are like the type of the steroid, the potency of the steroid, and the susceptibility of the patient themselves. The risk factor of the patients includes the age, the connective tissue disease, and other things. So when you have this risk factor, they may have eye problems. But when they have eye problems, just 50%, just half of them has just little elevation of intraocular pressure. About 1/3 of them has the intraocular pressure elevation between 6 to 15, and just about 4 to 6% of them has significant elevation of more than 15. And the other thing is, when steroid get into the eyes, it causes problem. So when it gets into the eye less, it causes problem less. When it never get into the eyes, it never have eye problems. So intraocular steroid is different from inhaled steroid, different from systemic steroid, and different from intranasal steroid. It's quite clear that if you use intraocular steroid, about half of the patient may have eye problems. And if you take systemic steroid, it gets into your body, to the system, so it can get into the eyes easily. Also for inhaled steroid, there is such evidence that it causes problem. But inhaled steroid and intranasal steroid are two different things. When the patient inhales the steroid, it gets into the lower airway and it absorbs through the respiratory mucosa of the lower airway, different from intranasal. About 30% of the steroid get into nasal mucosa, and the rest of them get into the oropharynx, and the patient swallows steroid into the stomach. And then there is a first pass metabolism for intranasal steroid, and there is rapid and extensive clearance following ingestion. And this rarely happens to inhaled steroid because most of the steroid get into the lower airway. The systemic absorption is significant for inhaled, but not for intranasal steroid. The dose is different. We use smaller dose for intranasal form of steroid. And for systemic bioavailability is quite high for old generation used for inhaled steroid, but it's quite low in new generation used in intranasal steroid. So when we spray the steroid to the nose, most of them get into the stomach, and there's a first pass in activation. And you can see that, for new generation, the percentage of systemic bioavailability is just pretty low compared to the old generation. Now we use intranasal steroid for rhinitis, mostly for allergic rhinitis. But although there is less evidence, it's used for non-allergic rhinitis as well. We use it a lot in rhinosinusitis, both acute rhinosinusitis. It can be monotherapy for acute. It can be adjunct to antibiotics for acute bacterial rhinosinusitis. And also for chronic rhinosinusitis with and without, we use it a lot. And also post-surgery, there are many forms. You may use steroid spray, you may use steroid irrigation or implant. And then steroid can cut the nasal-ocular reflex, so it can improve the eye symptoms. They can decrease the intraocular symptoms. For otitis media and adenoid hypertrophy, there's some evidence, but it's not recommended yet. It's just the optional. So because of it's commonly used and widely used for ENT, my friend Nas and I did one study to define the level of evidence of the adverse event in terms of ocular from the use of the intranasal steroid. Actually, we did not do meta-analysis, sorry. We searched the database. We used Medline and Embase databases. And we just included the study that reported the original data and measuring the intraocular pressure and glaucoma and cataract. So we exclude the studies that use the adjuvant use of other form of steroid, like intranasal plus oral, intranasal plus inhale. And for the outcome data, there is ocular pressure in terms of the pressure itself and the diagnosis of glaucoma. And for cataract, in terms of lens opacity and the diagnosis of posterior subcapsular cataract. So we have primary outcome for both ocular pressure and cataract. We screen the record 665 studies from the databases. And at the end, we included 19 studies. 18 studies just measure intraocular pressure, and 10 studies just measure cataract. And we included, actually we plan to do meta-analysis, but at the end we did not do that. The included studies is not very good in terms of blinding. Most of studies do not have the identical placebo, but it's pretty good in terms of allocation concealment, the incomplete outcome data, and selective reporting. Half of them is unclear for randomization, and half of them is sponsored by pharmaceutical company. This is the characteristic of included studies that's studying the intraocular pressure. So you can see that some studies are studying the pediatric population, and other study may study adult. The duration of treatment quite varies from just 14 days to 1 year, and the type of data include both the continuous data and dichotomous data. These are still the included studies studying the intraocular pressure, and there is case control, one case control, and also case series. And this is the characteristic of included studies studying the cataract. We included 6 RCT and plus 4 case series. And once again, some of them studying the pediatric population and other of them studying the adult. And the duration of treatment quite vary from 14 days to 1 year. The type of data is dichotomous and continuous. So for the findings, where's a laser pointer? Is this laser pointer? We do not have laser pointer? Okay. So I have one column of the number of control and the other column of the number of patients having the intraocular pressure elevation, and the other column for the number of the steroid group and the number of patients who have glaucoma after using the steroid. And you will see at the last column that all RCT reporting that no significant difference between groups, and also no significant, no significant, no significant, no significant, and no significant. And this is for the lens opacity. You will see at the last column that they showed us no significant difference for all RCTs. But if you look at the case series and case report, there are case saying that there have some patients, they use intranasal steroid, and then they measure the intraocular pressure, and they found the elevation of intraocular pressure, but there is no control group. So in terms of intraocular pressure, we included 4,300 patients from 10 randomized control trials. Duration vary from 2 weeks to 104 weeks. And this is the level 1 evidence support that there is a low risk of intranasal steroid use in the management of upper airway inflammatory disease, that there's no difference between the intranasal steroid group and placebo. And for the cataract, we included 3,000 patients from 6 RCT. The duration varies from 6 weeks to 104 weeks. And this is the level 1 evidence to show that there is a very low risk and there is no significant difference between the steroid group and the control groups. So, and this is because, I think because of the new generation of steroids is pretty good in terms of the glucocorticoid receptor affinity. They have the lipophilic properties, so it goes well into nasal mucosa, and if the patient swallow it into the stomach, there is a first pass metabolism, and the systemic bioavailability is pretty low. So it has been shown by many studies that the new generation may have as low as maybe less than 1% or 1 or 2% for systemic bioavailability. There's argument that there's one study identified 21 patients who had posterior subcapsular cataract. But if you read this article carefully, they have both intranasal steroid plus inhaled steroid plus systemic steroid. And the dose they use is very high dose. So there's confounding factors. And the same group reported 8 years later that they just monitored their patient, and the patient just continued the use of intranasal steroid, and there is a lack of any change in the term of lens opacity. So when we did the search, we found 116 review, which is non-systematic review, and out of 116, just 19 studies that reported original data. So it means that they just cited non-systematic review and cited again and recited again. And out of 19 studies, just 8 out of 9 are case reports. So it just has low quality of studies. So the case report and just literature reviews just increase the trend of warning. I warn you that steroid can affect the eyes. I warn you, and just increase the trend of warning and just create the environment of fear. So I think I'm also concerned about the eye problem. I'm concerned about glaucoma and cataract. So I will suggest that we should use new generation of intranasal steroid instead of old generation, having the hypophylicity and low systemic bioavailability. But when I say low, it doesn't mean no. So maybe just a small percentage, it can get into the system, may get into the eyes. So we should measure intraocular pressure before and after the use of steroid. The ophthalmologist suggests that 2 weeks should be reviewed about the intraocular pressure, and also they will assess the cataract, the lens opacity. So what about the patient who really have increased intraocular pressure? Can we prescribe intranasal steroid to them if we say that it's safe? From my studies, from the systematic review, we found that there were 5 studies that they did not exclude patients who have eye problem already. They also included that. And out of 5 studies, there are 4 RCT and 1 case control. And for all studies, they reported no change in terms of intraocular pressure and no change in terms of lens opacity, although the patient really already have eye problem. And among these 5 studies, there are 2 studies that just focus on patients who already have eye problem, which is one study is a case control study. They just defined 9,700 patients with glaucoma compared to 38,000 control. It is a case control study, and assess the use of steroid between these 2 groups. And they found that the odds ratio in terms of the dose of the steroid use and the frequency of the use of steroid has no difference in terms of odds ratio. And this is the RCT, just focused on the patient who really have ocular hypertension and glaucoma. And there's no difference between the use of beclomethasone nasal spray compared to saline treatment. I would like to acknowledge my friend Nas and Richard and Ray and Larry and my team in Sydney. We have a good team. So in summary, there's no evidence showing that intranasal steroid can create eye problem compared to the control group. So for normal patient, I think we can use intranasal steroid safely without fear. But for patients who really have eye problem for pre-existing ocular hypertension, still level 1 data suggests that still there's no effect. But we do not force the patient because it's a kind of art for the practice, right? We should discuss with the patient about the risk. If the patient are not happy, we should not force them. We should show it and discuss it with careful. So if they don't want to use, we should avoid the use of steroid. Thank you.